Good afternoon and good evening, and welcome to the final webinar of a three-part knowledge exchange series on country-led action to maintain provision of essential maternal, newborn, and child health services, voluntary family planning, and reproductive health care during COVID-19. I'm Debbie Armbruster. I'm a Senior Maternal Health Advisor at USAID and the MNH team point person on COVID-19, and I'm really honored to be here today. This series is convened by USAID's Momentum Country and Global Leadership Project, which is part of a suite of awards designed to work in tandem with country governments and local actors to provide targeted technical and capacity development assistance and contribute to the global technical leadership and policy dialogue around improving health outcomes for women and children. I know I speak for all of USAID in sincerely thanking the MCGL team for organizing this event. Today's webinar will highlight successes and challenges that countries have experienced in responding to the pandemic with an emphasis on maintaining high quality of care, increasing use of data, and ensuring gender-sensitive services. We will hear from global and country partners who will share both their successes and challenges, which we hope will ensure that best practices are disseminated and adopted during these challenging times. I have a few housekeeping notes as we begin this webinar. First of all, just to say that we're not going to be using any videos during the first half of this presentation to ensure that we have adequate bandwidth. And I would also ask, as we go along, I'm sure you will have questions for these great presenters. If you could please put them in the Q&A box that's at the bottom, and we will be taking audience questions during the second half of this event. I also want to make sure to mention, because everybody always asks, we will be sharing the slides. MCGL will share the slides of the webinar and a recording with all the attendees following this event. So I'm going to start by speaking a little bit to quality of care, which is a central element for reducing morbidity and mortality and achieving improved health for women, newborns, children, and adolescents. Our USAID MCHN office sees quality of care as a defining and unifying framework for our work, with MCH, immunization, nutrition, and WASH, including infection prevention and control, and our research component. We're active participants in the multi-country QoC network of maternal, newborn, and child health, which Dr. Lekaka will speak to, one of our presenters today, as he's been an active member from the start. Quality of care efforts focus on closing the no-do gap between evidence-based technical interventions and standards, the WHO maternal, newborn, pediatric, and just published small and sick newborn standards, and their reliable implementation in complex health systems. Continuous measurement, rapid change management, and shared learning are core quality improvement principles that are highly relevant in this COVID-19 pandemic. And I will say that MCGL has some really outstanding experts in this area. Quality of care approaches are critical for achieving safety in routine MNCH services. For example, physical distancing, reliable PPE use of hand washing, incorporation of COVID screening, and more, as well as use of evidence-based protocols for management of COVID-19 in our MNCH populations at risk or actually infected with COVID-19. The COVID-19 pandemic has highlighted persistent gaps in basic WASH and IPC standards and is a real priority of focus for USAID. But as I think we all know, quality of care has been severely strained by the COVID-19 pandemic. USAID, with you, is working to sustain quality essential MNCH services and voluntary family planning and reproductive health care and ensure that quality of care remains a high priority during this pandemic, when hard-won gains over these last years are being threatened in many countries due to major disruption in utilization and quality of essential services. The rapid transformation of virtual work processes, including this Zoom meeting, and virtual learning across quality improvement teams, blended digital and in-person healthcare, has normalized, or is moving towards normalization, new ways of doing business that can hopefully help accelerate quality of care and health system efficiency gains in LMICs during and beyond the COVID-19 pandemic. And with that, I want to turn it over to Joan Kraft, who's a gender advisor in the Population, Reproductive, and Health Office in Global Health at USAID. She's a gender advisor who has over 20 years of experience partnering with practitioners and researchers to develop and evaluate social and behavior change interventions for reproductive health. She provides technical assistance on the integration of gender into family planning programs with a focus on reproductive empowerment and intimate partner violence. And with that, I turn it over to Joan.
Thanks. Next slide, please. So thank you for inviting me to provide a few remarks today. Next slide. Most of you are familiar with these data on GBV pre-COVID. Suffice to say that the prevalence of GBV, including intimate partner violence, non-partner sexual violence, and child marriage, are said to constitute an epidemic. Indeed, because of these staggering statistics, USAID's health programs address the norms that perpetuate GBV in our social and behavior change programming and work with health systems and providers to identify and support survivors. The response to COVID is expected to exacerbate the conditions that give rise to violence. Based on assumptions about disruptions to GBV programs and increases in violence associated with sheltering in place, models project that there may be an additional 31 million cases of GBV in 2020 globally, for an average lockdown duration of 6 months. Next slide, please. Experiences with health crises indicate that disruptions and stress due to COVID exacerbate the gender norms and inequalities that contribute to GBV, as well as disrupt protective structures and services, thus making it difficult for survivors to get support. This diagram identifies multiple pathways linking pandemics like COVID to violence. Efforts to contain COVID have focused on physical distancing, which can lead to stress and results in disruptions including job loss and reduced availability of healthcare. Isolation of families may increase stress. With no easy way to let off steam, stress can exacerbate the financial insecurity and strains due to unemployment. These stresses can lead to new or more severe ongoing violence. Most shelter-in-place orders make exceptions for taking care of immediate needs. Because women and girls usually collect food, water, and fuel, they may leave their homes and in doing so may encounter a community with fewer safeguards against non-partner violence. Further, we started hearing about increases in child marriage and FGM, perhaps due to families needing the bride price or the lack of safe spaces. And has been described in other webinars, in this series, our response to COVID has resulted in difficulty accessing non-COVID healthcare and social services, including reproductive health services that may be able to identify and help survivors get to GBV support services. We know from experiences with Ebola and with COVID that it's imperative and indeed possible to adapt programming to address the stresses that increase GBV and to overcome the logistical challenges to maintaining healthcare and GBV services. Programs, for example, are addressing GBV and their risk communication and community engagement work, and they're looking toward digital solutions for social support for survivors. I look forward to hearing more today about how programs are addressing GBV and other issues associated with COVID, our COVID response. Next slide, please. Thank you for listening, and please do reach out and share resources or ask questions. Next.
Okay, thank you very much, Joan. Next, we're going to hear from Dr. Deborah Jackson, who's a professor and first Takeda chair of global child health at the London School of Hygiene and Tropical Medicine. She was previously a senior health scientist in the health section of the UNICEF Knowledge Management and Implementation Research Unit and has qualifications in nursing, public health, epidemiology, and biostatistics. Over to you, Dr. Jackson.
Okay, great. Thank you. Good morning, good afternoon. Thank you for joining. I'm going to speak briefly about a new guidance, which is actually being released in the next week or so on monitoring the effects of COVID-19 on essential services for reproductive, maternal, newborn, child, and adolescent health and nutrition. It's being released by UNICEF, WHO, World Bank, and UNFPA. But as you can see below, the working group had over 40 global experts from 15 different organizations. Basically, instead of everyone doing their own, for once people actually all came together and we've done this guidance. It's part of a larger suite of documents being released by WHO on monitoring effects of COVID. Next slide. So just a little bit of a background, COVID-19, like previous disease outbreaks, is resulting in RMN, CAH, and nutrition service disruptions in affected countries. The data to date have been collected have limitations. They're usually pulse or other surveys, are based on key informant reports, not necessarily service data, though later in this talk, you're going to actually see some real service data, which is some of the first coming out, which is very exciting from Afghanistan. And then, but international attempts to collect have only been limited cross-country and cross-sector data. So we need better data for understanding, but more important, we need regular monitoring tailored to the local context. And so that local managers can monitor how their services are being affected and how to mitigate those. So it's so they were recommended to prevent and address resource diversions and related challenges. Next slide, please. So just this guidance was created to support monitoring using existing program data as the preferred source to inform program adjustments meant to ensure RMNCH and nutrition essential service availability coverage. The graphic on the right, you can see it might be due to supply reductions, access reductions, so transport disruptions, demand reductions because people are afraid to come to health services, workforce reductions because providers are sick, or they might be afraid to come to work if they don't have PPE. So this is about monitoring those potential disruptions. Next slide, please. As mentioned, this guidance, it complements the WHO Maintaining Essential Health Services COVID-19 operational guidance, which the EHS guide, which was released in June, and is a suite of guidance on monitoring across various programs, which is being released from September through about November this year. The guidance is using existing routine data to identify changes in utilization of RMNCH services, analyzing and interpreting the data, and using the data to inform action. Next, please. So what was the selection of indicators? I mean, we know that you know, any standard health management information system will have hundreds of indicators. So we focused on getting to a sort of set of sentinel indicators for the most essential services to protect lives. So we also focused on recognized or valid standards of well-established definitions of numerators and denominators. We looked for indicators that were in common use in existing routine health information systems in most LMICs, because we don't, in a time when people are already overburdened, we don't want to impose additional burden on staff, so we want to use available data. Representative key elements in RMNCH nutrition essential service delivery, and capture effects on the largest portion of the population based on their availability. So from previous time periods or geographic locations, and suitable for informing clear and responsive action. You can see that we did 33 indicators were selected across reproductive health, maternal and newborn health, child health and immunization, nutrition, cross-cutting, outcome and impact, plus additional indicators that may be relevant in certain contexts. Next, please. So how can you use the indicators? Basically, you're going to need to select the areas and indicators most appropriate for your work based on existing data systems. So consider which data need to be reviewed at what level of service provision and level of authority at which action can be taken. So you're looking to adapt these 33 to your situation. If the data are not readily available or formulated or reported slightly differently, then use the available indicators as proxies. So, if you're interested in antenatal care and you have a measure of, say, antenatal 4 and we're looking for antenatal 1, then you then use whatever you have for antenatal care, as opposed to trying to do something new. What you will be expected to do, though, is you might be using other qualitative or quantitative data sources to help contextualize the trends in routine data. Next, please. So once again, using existing data systems, you can do minor adaptations to existing systems and reporting tools if necessary. And the most likely thing there is that often your HMIS, your data is delayed, or you can't see it monthly, you see it quarterly, in which case these 33, you might want to see them more often, like twice a month, once a month. You might want to focus on making sure that the quality is still there. So using HMIS or National Health or other service delivery registers, so it could be LMIS or things like CRDS if you've got a good system. But you might also have to do additional data sources, and these could be surveillance systems, rapid SMS polls, facility level rapid assessment surveys. WHO released a suggestion for that, I think September 3rd, so you could look that up. Home-based records, registration systems, special surveys. But you want to establish mechanisms that allow health workers to see how data contributes to action, so that they can see their data, they know what's being disrupted, and they can take action. Next slide, please. So the key principles for data analysis are monitoring indicators over time to compare trends for the same time periods over different years, quarters, or months. So example, comparing data from January to March 2020 with data for January to March 2019. So once again, you're going to need existing data because if you need to look at historical trends, you need data that's already there. You also want to be concerned with reviewing the completeness and timeliness, as well as contextual information when interpreting these trends and possible service disruptions, because of the increased burden of care or lack of service providers, your quality of or timeliness of your HMIS data may have also reduced. Next slide, please. So you also want to use data to inform mitigation strategies. So, based on that graphic that we saw earlier on the potential places for disruption, you can see, supply and equipment bottlenecks, you'd have to look at supply chain involving private sector. These are just potential mitigation strategies. And for looking at these potential disruptions and strategies, that once again, you can use the EHS guide, which is there. The link is there for you to see. Next slide, please. So that's it. This was just a brief highlight. This is actually the first presentation of this guide to a public audience. We'll be presenting it over the next few weeks. And you'll be able to find this guide in initially in the WHO COVID-19 resources, as well as the Maternal, Newborn, Adolescent Health and Aging Program website. So thank you.
Okay, great. Thanks very much, Dr. Jackson. That was very interesting. Next, we're going to have Dr. Gertrude Oda Zugo, who is a Senior Reproductive Health Manager in the Health, Population, and Nutrition Office in USAID, Nigeria. Excuse me. She serves as a primary focus on equitable access to quality health services, especially at primary healthcare and community levels. And as a point of contact for gender-based violence, Dr. Oda Zugo supports the integration of gender and gender-based violence services within the broader reproductive, maternal, child, newborn, and adolescent health and nutrition continuum of care. With that, over to you, Dr. Oda Zugo.
Thank you very much. Good morning, good afternoon, everyone. During this presentation, I will highlight the impact that the coronavirus pandemic has had on services for gender-based violence in Nigeria and strategies for overcoming this. Next slide, please. Yeah, so this is the presentation outline. The background will include data on what the GBV picture was before the COVID-19 pandemic, how Nigeria and the health system is responding to the impact of the pandemic on GBV services, and I will highlight the gaps that still need to be addressed. Next slide, please. So this slide provides a brief background on some of what we already know about GBV, its various components, and relevant data depicting the picture, what the picture was even before the pandemic. As you can see, 30% of women and girls of reproductive age have experienced at least one form of sexual violence, with intimate partner violence accounting for 2/3 of this number. The data presented here are all from the 2018 National Demographic and Health Survey. Next slide, please. So violence against women accounts for a great percentage of GBV cases in Nigeria and is noted to increase during epidemics, and more so among vulnerable populations like people living with disability and displaced populations. Real-time data from the Nigeria CDC show that more men than women contract COVID-19, and also the death rates are more in men than women. This differential could be due to more men getting tested than women due to the low social capital of women. Women are more likely to suffer the secondary effects of the pandemic. Next slide. These secondary side effects stem mainly from the fact that GBV survivors had to be locked in with their perpetrators. Remember that we mentioned that intimate partner violence accounts for about 58% of GBV cases in Nigeria. Effects of the lockdown include stress, disruptions to social networks, and to access to sexual and reproductive health services and commodities. The resultant increases in domestic violence have led to increased numbers of physical and mental injuries, unintended pregnancies, and sexually transmitted infections. The data presented here is from NOI polls, and this is available online to the public. Next slide, please. Now let's look at the various steps taken by governments at national and subnational levels to curb GBV and minimize the impacts that COVID-19 has on GBV in Nigeria. The government of all states in the Federation recently declared a state of emergency against gender-based violence, and this resulted in various actions taken by relevant stakeholders. There is growing emphasis on reinstituting the sex offenders register. State governors in most states, especially in northern Nigeria, have introduced tougher punishments for offenders, including the death penalty in some. And there is currently a bill for an act to prohibit the stigmatization of victims of rape and insurgency, currently at the floor of the Senate. Next slide, please. Now, what is the health system's response to COVID-19 as it relates to GBV? First, with better coordination of efforts of donors, partners, and the government, GBV services are considered essential service. Thus, we have GBVs addressed during multi-sectoral and integrated Rmsh service provision and programming. Partners continue to support government at federal and at state levels to build capacity of the health workforce and allied parastatals to the prevention of and management of GBV survivors, including the establishment of effective referrals to other non-health services like legal, livelihood services, psychosocial services, and so on. Next slide, please. So essential Rmsh commodities that now include emergency contraceptives, antibiotics for STIs, post-exposure prophylaxis for HIV, diagnostic equipment, and very importantly, protective gears and infection prevention materials for healthcare workers and their clients. The UN agencies, in collaboration with other donors and partners, are working on instituting the appropriate policy and legal frameworks that will ensure continuity of GBV services, reduce vulnerabilities, and promote gender equality. However, we know that gaps still exist. As pointed out by Deborah in her presentation, data is key, and Nigeria needs now to focus on strengthening its routine data system for evidence-based, more real-time programming. The social media plays a huge role in community engagement and citizen participation, but a lot more needs to be done to increase ownership by and participation of the community, traditional and religious institutions in order to reduce the associated stigma and shame that hinders reporting by survivors, as well as for behavior change and policy and legal backing for addressing gender-based violence issues. Next slide. So still on the gaps, the government is still in the process of working out modalities for state-specific gender analysis that will inform further implementation of GBV programming. The guidelines for sustaining RMNCAH plus nutrition services in the context of COVID-19 is underway and still to be finalized. Available resources are insufficient for maintaining adequate protective and infection prevention equipment, and a lot more is required to increase awareness of and citizen participation in issues around gender-based violence. Next slide. So in conclusion, we recognize that for our plans to be more effective, they need to be grounded in strong gender assessments and quality routine data. Government needs not relent in its effort at greater stakeholder involvement. Now is the time to ensure coordinated efforts to institute a system that is sustainable beyond the current pandemic, adaptable for future epidemics and pandemics. Next slide. Thank you very much. So that was a brief on the impact of COVID-19 on GBV services in Nigeria.
Thanks so much, Dr. Oda Zugo. That was incredibly important information that I'm sure the participants appreciate. And next we're going to have Dr. Zelaika Anwari, who previously served as the RMNCAH Director with the Ministry of Public Health of Afghanistan from February 2015 to August 2020. And she worked in close coordination with international development partners, national, international, non-governmental organizations, and communities. She is currently the Senior Principal Advisor for Integrated Health Service, Reproductive, Maternal, Newborn, and Health, Child, and Adolescent Health for Management Sciences for Health, and provides technical assistance to the Ministry of Public Health in Afghanistan. With that, over to you, Dr. Anwari. Dr. Anwar, you may be on mute. We can't hear you.
Yeah, sorry. Thank you very much. Actually, in this presentation, I'm talking about the tools that we are using for data utilization, including the Rmsh Scorecard and the HIS2. And also we'll have an overview of the Rmsh some key indicator status. But before that, I would like to have a quick overview of the health system in Afghanistan. Actually, our health system was completely destroyed during the civil war and also during the Taliban regime, and between 1992 to 2001. And after the fall of Taliban in 2001, the government of Afghanistan, with the support of international community, experienced a new mechanism of service delivery, which called them contract out. And this mechanism, the NGOs providing public health services through the standard packages for health services that we call them basic package of health services and essential package for hospital services. And the government role is the stewardship role. With this, I'm now going to explain the data flow that how we are using. Please go to the next slide. Yes, here. Actually, we started the implementation of data utilization in the Rmsh Directorate in beginning 2016 after developing the Rmsh Scorecard. And with this, the provincial team, mostly the RH and reproductive the child health officers, they are retrieving data from HMIs and then putting in the Rmsh Scorecard, which is an Excel sheet-based tool, and reviewing the data and providing feedback to the frontline health workers and NGOs, as well as sending feedback reports to the Ministry of Public Health. The Rmsh Directorate. Rmsh Directorate also reviewing the data, providing feedback to the field or provincial team, as well as making a summary of this and submitting the information or summary sheet to the Performance Management Unit of Ministry of Public Health, which is responsible for evaluation of or appraisal of the NGO's performances, and using different platforms to review this data, for example, face-to-face meeting with implementing partners and technical departments. And also we have a mechanism of quarterly review or semi-annual review workshops and reviewing this data jointly and making a joint decision. For example, if there is need for improvement, they are making a kind of performance improvement plan. If there is a improvement in the trend of data, then it's considered as a best practicing and sharing with others. Now, so these are about our practice. And as I talked about the RMSH scorecard, it is a tool to improve accountability for RMSH services at district and provincial level. And also the focus is more on identifying problem and solving this, and also making a kind of improvement plan, and also encouraging the provincial team to utilize data. And also it is a kind of routine management tool. We also use the scorecard is contain different key indicators for RMSH. Please go to the next slide. These are indicators for maternal and newborn health, family planning, child health, nutrition, and human resources. And these are about 16 indicators that we are regularly retrieving data from HMIS and reviewing. Next slide, please. Yeah, the RMSH scorecard is a color coding tool. As I mentioned earlier, this is an Excel-based and user-friendly, and the provincial team, when putting the data, it will automatically shows the status in 3 colors, like green for the ideal situation and red color for the worst condition. Yellow is in between these. And also we also showing the figures and arrows, like compare the data in but the last quarter by ups and down arrows. As you're looking in this slide, this is a snapshot of the RMSH scorecard and key indicators and picture of the whole country in regard to these indicators. Beside that, we are also using our data in the form of line charts, bar charts, to make it more understandable for the team during the review workshops, and having a kind of discussion, like this is an example of the low birth weight that during the whole year we are looking the trend and see whether it is improved or not. If not, why? So this kind of discussion we have, and try to make a practical action plan to improve the situation. Next slide. Yeah, this was the scorecard. Now about DHIS2, which is recently introduced, and fortunately it is a very good tool for us to have data from the past years and easily retrieve this, and also having charts and graphs, all the things. For example, during COVID-19 time, we had a very good comparison to see the trend of RMSH indicators. We had a comparison of January to May 2019 with the January to May 2020, or this year, and we got a very interesting information, like you are seeing in this slide, that the yellow bars or oranges showing the this year 2020 figures, that we are observing a significant reduction, and the trend of indicators the same for assisted delivery, and also at facility level, and also at the home level. And for cesarean section, the rate is also reduced, the same complication of maternal death reduced, but it doesn't mean that we are in good situation or the system is improved. It was because of COVID-19 and restriction on movement and low utilization of the services. This also showing the newborn and for family planning, the stock out, which was a main problem that we faced. Next slide, please. Next slide. Yeah. The next slide, if you see here, is we are observing a huge, I think, stock out of family planning in across the country, like 25 provinces out of 34 faced with the stock out of IUDs. The same for oral contraceptive, injectable, and condoms. We face with the stock out. And this also another comparison for family planning visits during COVID and last year. This also, there is a significant reduction in the family planning services and also community distribution during COVID-19 time. Next slide. Yes, beside this, that however, we started this practices since 2016, but we faced with so many challenges like poor supportive supervision and monitoring affect the data quality, especially in the hard to reach area or insecure, and also poor participation of provincial team to the data review workshops. Is another challenge, or low capacity of provincial public health officers, and also high turnover of provincial public health officers due to low remuneration or motivations. To address these challenges with the use of technology, we can provide technical assistance, and I encourage that we should provide such kind of support to the provincial team, also organize workshops at the provincial level and incentivize provincial public health team by provision of technical assistance and office facility or other motivating factors to improve the situation. So that's all. Thank you very much.
And thank you. We really appreciate that presentation. Seeing data is always important, as Dr. Jackson was pointing out. It helps us be able to adequately manage and address the pandemic as it moves forward. Our next presenter is Dr. Andrew Lakaka. He is currently serving as the director of the newly established Quality Management and Digital Health Directorate in the Ministry of Health and Population in Malawi. He is responsible for providing strategic leadership and coordination of quality of care and digitalization in the health sector. He is the national coordinator of the Malawi Health Situation Room, which is advancing data usage for strategic decision-making through virtualization at all levels. And he leads the global network for improving quality of care for mothers, newborn, children, adolescents, and youth. Over to you, Dr. Lakaka.
Okay, thank you very much, Dave. Thank you, colleagues, wherever you are. I'll be presenting on quality of care to ensure continuity of maternal, newborn, and child health services during COVID-19, and it's a case study of Malawi. Next slide. So it's not news. We know how COVID-19 has disrupted health services globally, and Malawi hasn't been spared. We have, out of the 5,772 confirmed COVID-19 cases, we've had 40 pregnant women and unfortunately 1 maternal death out of 179 confirmed COVID-19 deaths. We've seen general shift of attention globally, even in Malawi, of resources and focus from health systems proper to support COVID-19. And the situation has been quite alarming in Malawi since March 2020. However, when we look at the health system, it has responded very differently in terms of impact. Next slide. So we selected a few indicators from JHIS2 just to look at the impact of COVID, and for specifically maternal and newborn, as well as the indicators that we chose for family planning, there was clearly insignificant effect and impact from COVID-19 on a few selected indicators, as can be seen on the graph. Next slide. Also, when we look at the further impact of COVID-19, there's been a huge concern about the rights of women being infringed during the era of COVID-19 pandemic. And when we consider the consequences, just as the case for Ebola in Liberia and Zika in Brazil and other countries, we've noticed high teen pregnancy rate in some districts in Malawi. Actually, one district reported over 5,000 teen pregnancies in 3 months. Also, due to limited attention to maternal and newborn and focus to other indicators, mainly related to COVID-19, we've seen an increase in maternal morbidity as well as neonatal mortality rates going up. Also, the public has been afraid to seek care in our facilities with the fear of contracting COVID. As also alluded to the presentation from Nigeria, some of the policies that were set during COVID-19, for example, staying at home policies have led to increase in sexual and gender-based violence. Let's go to another slide. So we also wanted to see clearly how COVID-19 has affected other programs related to MNH. And as can be seen in the table, there's been a significant impact on the women who were seeking care for cervical cancer in Malawi, as well as youth-friendly health services, HIV testing, among the youth. All these indicators have been significantly affected by COVID-19 in Malawi. Another slide. So what have been our concerns when it comes to quality of care for maternal and newborn as well as child health services in the era of COVID-19? Issues to do with safety of health workers has been paramount, as well as the safety of patients. We've had over 670 health workers who contracted COVID-19, and unfortunately 3 died. Long waiting times has really been another issue, mainly for women with chronic conditions like cancer and gynecological conditions. So they had to wait longer, and this impacted negatively on client satisfaction. Also, I must indicate that the new norm, the social distance, and the limited time for physician and patient consultation has affected greatly on patient-centered care, among other areas. Let's go to another slide. Now, in Malawi, Malawi as one of the countries that is in the global network for improving quality of care. One of our main goal is to reduce institutional mortality by 50%. That's maternal as well as neonatal within 5 years. And the network has got key strategic objectives. In short, we call them LALA. That's leadership, action, learning, and accountability. Our strategies to respond to COVID-19 mainly in ensuring that quality of care for maternal and newborn essentially follow on these 4 strategic areas. Next slide. So we ensured that there was proper leadership. Immediately we had the concern on the outbreak. We noted that advocacy will be paramount. So to advocate better, we ensured that the structures were in place at all levels of care, from community to national level, to ensure that quality of care for maternal and newborn are streamlined, as well as making sure that policies and protocols guidelines are readily available. Although there were challenges in terms of making sure that the ever-changing policies are reaching where it matters on time. We also ensured that there were assessments immediately as part of advocacy for maternal and newborn. We made sure that there should be an assessment to look at the impact of COVID-19 on maternal and newborn child health services. We conducted an assessment, and at the moment we are carrying out an EMOC assessment across Malawi, also focusing on the quality of care for maternal and newborn. We believe this has been influential in advocating for attention towards maternal and newborn. We also moved into innovations and technology, sample transportation, as well as commodity supplies like family planning, emergency supplies, immunizations. We had to start using drones to provide those services to rural areas. And also we designed health systems, making sure that they are responsive to COVID-19. Our facilities had no structures to support pregnant women who had COVID, and who needed support for delivery, for example. So we had to redesign services, making sure that amenities are available to support that need. Decongestion of facilities was one of the key and paramount areas. We had to institute and advocate for long-term family planning measures, for example. At one point in time, we stopped even providing immunization to under 5 children, as healthcare workers were afraid of getting infected. So we had to come with innovative ways, including appointments for immunizations at community level. Digitalization has been also paramount. We had to make sure that all data for maternal near misses, maternal deaths, as well as COVID infections, mainly among pregnant women, as well as neonatal indicators, are reported on real time. So we set up a system across Malawi, and as I'm talking now, we get notification in real time for all maternal near misses, maternal deaths, as well as NM pregnant woman who has got COVID-19 in facilities. Next slide, please. We also facilitated learning and virtual collaboratives where districts could learn from each other on maternal and newborn, mainly managing managing pregnant women as well as maternal services during COVID-19. So these weekly these virtual collaboratives are taking place on routine basis. We have also quarterly reviews that are virtual and they are providing avenue to share data. We instituted and strengthened the accountability mechanisms to make sure that voices of patients are taken into consideration. So in Malawi, we have a hospital ombudsman program where we have designated officers who are independent of health system, but they are engaged to get concerns from the public or complaints that patients have in the course of seeking care in our facilities. So we strengthen this, looking at also opportunities that we had unemployed graduates just loitering around, including students. We engaged them quickly and deployed them to support the hospital ombudsman platform. We also ensured that we should be accountable in terms of the quality of services that we are providing. So as I've indicated already, digitalization has enabled us to have real-time data systems, and our dashboards are now available to provide an update in real time on maternal deaths, near misses, as well as neonatal mortality. Can go to the next slide. Yeah, so I want to thank you and welcome any comments and questions. Thank you very much.
And a sincere thank you to you, Dr. Likaka. That was very interesting. And now we're going to be having some Q&A. And I thank everyone who's been putting questions into the chat box. We're going to do our best to have these questions answered. And I want to start with a question to Dr. Oda Zugo. And can Dr. Oda Zugo share more details about Nigeria's supportive supervision approach to support health workers, given the logistic and resource challenges that supervisors face during the pandemic?
Yes, thank you, Debbie, for that question. So there are two parts here. First of all, the government and partners have ensured that there are adequate PPEs and IPC materials and equipment made available at facilities and institutions. And second of all, managers now have the capacity to be able to provide virtual supervisory support to frontline healthcare workers in cases where physical mentoring is not possible. These supervision checklists are available on mobile platforms like phones, tablets for ease of data collection. And there are dashboards for real-time evidence-based decision-making from the health facilities and sexual assault resource centers to the LGA department and to the state. And then challenges are addressed and taken back down. Over.
Thanks so much. Appreciate that. Next, we'll have a question for Dr. Anwari. How are you collecting data with the lockdown restrictions during the pandemic? Dr. Anwari?
Thank you very much. Actually, during a lockdown period, it was just a lockdown wasn't just a few provinces, not all country. And on the other hand, the health system, as I mentioned earlier, that it is running by NGOs. So they're also receiving or paying against their performances. They try to open the services, and during the COVID time, our health facility was open. But the thing that people was not coming to the health facility to receive the services. And for sure, we have a very strong HMI system, and the data coming from health facility to the provincial office, and then coming to the central ministry, and all data is going to sync there. And also, we are also using data from DHIS2 to review and provide feedback and have discussion on the data.
Thanks very much. It's a challenge, a real challenge. And now, Dr. Lakaka, can you please share details of how you use drones for delivery of supplies? How was it planned, and what challenges did you encounter? Over to you.
Thank you very much, Deb. We initially underestimated the impact of drones in the service delivery. Mainly at the beginning of the pandemic, we initially were relying on normal routine transportation of commodities and supplies. One area that we noted were family planning commodities were not available in most of the rural areas. And with the lockdown initiative restricted movements, even though we allowed only essential services, but the whole transport system had collapsed. Also, supplies like Koki clamps for newborn, lignocaine, oxytocin, and some other emergencies commodities, including vaccines, couldn't be moved from some districts to other districts. So until we had to engage drone companies at an, of course, in an emergency, and they helped a lot. They helped a lot to make sure that are available to rural areas. Challenges were many. Some of the routes, even for the drones, were new. They weren't mapped quite well. The community was not sensitized properly. When there is an emergency landing, some communities would destroy and even dismantle all the commodities, throw them away because there was no proper engagement with the community. Resources to sustain drones, I think, is still becoming a challenge. Even though at the moment that we have few numbers and the pandemic seems to be within control, we are still facing now high need to get drones to support rural areas. But the resources are very limited. Some of the drone companies can't continue to support us. So I think those are some of the experiences and challenges that we know.
Thanks so much. Very interesting, and great to see how you're trying to address all these challenges. So I'm going to go back to Dr. Oda Zugo and ask her, what are some of the effective strategies for reducing stigma and discrimination for male survivors? Are there resources that can be shared? Over to you, Dr. Oda Zugo.
Thanks again. Thank you for that question. So first of all, in Nigeria, we don't have enough data that speaks to men as GBV survivors, you know, and that is why I had mentioned that one of the gaps is really understanding what is going on with GBV, sex disaggregated, and how it affects men differently from women and vice versa. You know, but I would want to think that if we, after our assessments in this country, we find out that there are actually increasing numbers or even numbers of male GBV survivors in the country, that strategies will be targeted at male-specific interventions, just as we think for women. So I guess the short answer is that we don't have that that data yet, but you know, behavior change communication is key to addressing most of all our health challenges, including gender-based violence, whether for males or for females. Over.
Thanks so much. Now we're going to go to a question for Dr. Anwari. How are you using the data you presented to inform and help improve community health worker response to the slowing of service uptake? Over to you, Dr. Anwari.
Okay, thank you very much. This is a really good question because still we are not in the phase to communicate data with the community level, with the grassroots people. So I think we have very good platform right now. We have community development councils. We have the community health shura or council, and also family health action groups. We have community health workers that voluntarily providing some services. So these, we are able to mobilize these platforms or resources, and through the community health supervisors, which is participating the Provincial Public Health Coordination Committee meeting, which is monthly based meeting, they can share this information to the community level through, they have also a kind of monthly meetings, maybe share or transfer data information to CHWs or community health workers, the same as the forum that I mentioned, and also communicate with community elders. And we also plan to have a kind of new approach to engage male or men involvement in RMSH services. So this is also another good opportunity that we can use them to share information, especially data and status of indicators with the community, and encourage them to take part and have increased utilization of services. Over to you.
Yeah, thanks so much. A great response. And Dr. Lekaka, I'm coming back to you. Could you share a little bit more about learning districts in Malawi? There's a few questions about that. So over to you.
All right, thank you very much, Deb, and thank you for that question. I think from the network guidance, global network for improving quality of care for maternal and newborn, there is a guidance on approach to reducing mortality, institutional mortality. And what we did for Malawi initially was to define quality in our local perspectives, what do quality mean? And we ensured under the structures that I've already highlighted, the objectives, leadership, set up the entire leadership, and come out with as a big action was to come out with a roadmap. What does it take to achieve a goal? And we have a roadmap that we developed locally with support from various partners, including USAID. And we, under learning, we decided to choose learning districts. We know that for an improvement, we cannot start big. We needed to start small. So we chose 6 districts that had poor indicators for maternal and newborn. And also we looked at a number of, we had a criteria to select those learning districts. And within the learning districts, we had the selected facilities. So in total, we have 6 districts, and we have, in each district, we have 3 hospitals, 3 hospitals from various levels: health center, district hospital, and for those that have got the central hospitals, we chose also tertiary hospitals. So the idea is that we focus our attention for improvement interventions in these learning facilities. So we have like 24 learning sites in 6 learning districts. So each district has got 4 learning sites. So we focus our attention in these facilities to see what is working, what intervention is working to reduce institutional mortality. And we scale out best practices, as well as also what does not work, because quality improvement is not all about what is working, but also what is not working. Because what is not working can help for others to learn not to do the same things. So these are like landmark or benchmark facilities where other districts as well as facilities can learn from. So essentially, by learning districts, that's the idea. I must indicate that it has got its moral issues and ethical issues. The more you improve quality of care at one facility, the more you bring in addition, and you bring problems. So we've noted that, for example, the balancing measures, we are seeing lots of deliveries, congestion in these learning districts. People are moving away from areas that are not learning districts, going where quality of care seems to be improving. So that's something that is coming out of also that cascade. Thank you, Tim.
Yeah, you know, we have to give communities credit, and they choose with their feet when they realize that quality is improving. So yes, that's true. So now another question for Dr. Oda Zugo. What work is happening to analyze the impact of COVID-19 on women versus men, both in terms of health and gender, and to differentiate the responses accordingly? Oh, did I ask that question?
Yes, I think I got it. I hope others got it.
Yeah, it got repeated. Sorry about that. Is there evidence to show that interventions to improve the IPV situation have been effective? Apologies for the mistake. Over to you.
Okay. Yes. First of all, we have data, from sexual assault resource centers that showed that during the first few months into the pandemic, that access to utilization of services reduced because of analysis of the trends data. However, with interventions and government ensuring that GBV remained an essential service and considered as such during the COVID-19 pandemic, we saw more and more survivors now reporting more to the health facilities and the sexual assault resource centers. So for us, that was an improvement, and that there were actually healthcare workers at the health facilities to be able to attend to survivors. Also, very recently, the National Health Management Information System tools captures data on GBV. So even at the primary healthcare centers, we're able to collect information. In fact, health facility workers are trained to be able to prompt or probe, and get information and inclinations of gender-based violence, especially intimate partner violence, and they are able to report that not only to the federal ministry, to the state ministries of health, but also to the Ministry of Women Affairs and Social Development that usually acts as the link not only to provide support to survivors, but also to ensure legal backing, the police, the judicial system, and needed psychosocial support. Yeah, so yes, we have, the data is showing that we're actually improving, and more people are more confident, though it varies across regions in the country, but more and more people are now confident to be able to come back and come to the centers and report. And then even in northern Nigeria, with stringent measures being taken by governors now, survivors now are now more confident that, something will be done, and they're able to speak up. So we're seeing improvements at both the healthcare institutions level and at the level of the communities. Over.
That's exciting. That's really great to hear. I'm hoping other countries are moving in that direction as well. So the next question is for Dr. Anwari. How do you intend to overcome supply-related issues, especially for contraceptive services? Over to you.
Oh, that's a kind of, I think, difficult question to respond, because at the government level, we don't have that much resources to provide supply to the health facilities. And also, because we already contract with the NGOs, and NGOs are responsible to do this. And we also put family planning as a key indicator in the pay for performances, but later on be removed due to some concerns and distraction that we face with. So this is a big challenge right now. And also UNFPA is also provide us supply previously, but due to some, again, budget constraint, they are also faced with some challenges. And generally, we can say that it is a big problem. Where we have right now ASMO, which is a social marketing organization, and they're also distributing or repacking the family planning commodities, and it is available for private sectors to make it available in the local market. But for the public facilities, the NGOs should buy these items. So this is a big challenge that we face, and we discussed with the leadership of ministry to the advocacy forum that we had, that we find the solution for this.
Yeah, that's a tough one. I hope you are successful, and thanks for all your work on it. Now I'm going to go over to Dr. Likaka again. So Dr. Likaka, have you seen any impact on adolescent girls and young women? How have programs been tailored? How have programs tailored approaches for young people? Over to you.
Yeah, thank you very much, Deb. I think COVID-19 has really impacted greatly on young people. Young people, generally services are not responsive to the needs of young people. Sexual and adolescent health services are not that accessible in our setting. I'm sure in most of African countries, mainly for young people. Already, even without COVID, for young people to access services is a challenge. There are so many social norms, cultural norms, providers who are not friendly and accessible, the age differences, some are like parents, challenging, so challenging. The environment where young or adolescents find themselves in our facilities is quite appalling, so challenging. Actually, we are puzzled that an adolescent girl or a boy can't find a proper in a hospital. It's difficult to know where to admit them. There are no specific wards for their privacy, no specific beds for their age, length. So that's in normal sense. Now with COVID-19, adolescent, most of the services for adolescents were taken like non-emergency or non-essential services, and were suspended. teen clubs were all suspended in our country, and up to date, they are no longer available. So what we've noted, even after closure of schools, we've seen an escalating alarm of teen pregnancies. By having teen pregnancies, we should anticipate that there are sexually transmitted infections. We can't anticipate even the magnitude of infections like HIV in that aspect. So I would honestly say that this is one area that COVID-19 has impacted us. Unfortunately, the social gatherings are still limiting opportunities that young people can gather or can get support among themselves. So as a health sector, we haven't responded that much to the needs of adolescents and young people in the pandemic of HIV. I think the focus has been purely looking at addressing COVID, but forgetting young people. I would say that young people have been left behind during COVID-19. Thank you.
And thank you. That's a real problem. And I think it's probably not only true in Malawi, it's likely to be true in other countries as well. So I'm going to go back to Dr. Oda Zugo. I have a question. It's a little bit off of our focus on women in this COVID context, but I'm wondering about children and early child marriage and the effect of violence on them. It's been another topic that we've been concerned about in our MCH division. And I don't know if you have any data or if you have anything to share on that topic. Over to you, Dr. Oda Zugo.
Thank you, Deborah. So very soon we're going to have data. Currently, we are relying on survey data, the National Demographic and Health Survey, and any other surveys that other partners are conducting. However, there hasn't been a lot of focus on child and early forced marriage. But as you know, and maybe a lot of people don't know, USAID is focusing in that area. And at USAID Nigeria, we're very soon rolling out a program to address the different levels of gender-based violence with a lot of emphasis on addressing child and early forced marriage. We know that it won't be easy, especially because we need to be able to shift a lot of social constructs at the level of traditional and community institutions, you know, those factors that affect or rather that impact child and early forced marriage. We know poverty from data and from papers that poverty, you know, plays a huge role in girls being given out in marriage, even boys in some parts of Nigeria. But we are engaging through the MCGL activity to try to address this in states that are most affected, which is more in northern Nigeria. So Deborah, very soon you're going to have information and we'll be able to share that with the world. Over.
Okay, so I'm going to go to Dr. Anwari, and it's back to community health. What opportunities are there to transform the community health information system so that it can bypass provinces and provide real-time surveillance and also obtain real-time feedback to make the community level system more responsive to dynamic shifts in the service environment? Over to you.
Yes. I think based on the recent Afghanistan health survey, over 2/3 of households in rural areas and 90% of households in urban areas own a mobile phone. So this is, there's no doubt that all health care providers across the country, they have access to mobile phone. So I think this is a excellent opportunity for us to take the advantage of this technology and connect the grassroots level or frontline health workers to the Ministry of Public Health relevant departments they share information and receive real-time feedbacks from the relevant departments, as well as if there are any technical assistance they needed, we can provide them. So this is, I think, the best opportunity for us. We can use to improve the situation, and also having a strong relation with the community health workers and the first or frontline health workers.
Thanks very much. I'm sorry, do you have more?
No, thanks, that's all. Yeah.
No, that was a great response. A lot of work to do, for sure. And now I'm going to come back to Dr. Likaka. And the Multi-Country Quality of Care Network for MNCH was launched in Malawi in 2017. And I remember you were one of the leaders at the beginning. With your strong support, and Malawi continues to be an active participant in this WHO-led QoC network. Can you please comment on how Malawi is leveraging the QoC network strategies and or resources as part of its response to the COVID-19 pandemic? For example, WASH, IPC, QoC standards. Over to you.
Thank you very much, Deb. I would say that the network has facilitated to put a framework where I think your standards for IPC followed what we already reinforced through the network. The roadmap that we set up, the standards that we are following for infection prevention and control in all facilities that are learning sites became a model when the COVID-19 came in. So the learning platforms that have already indicated, essentially we've been using the initiatives that were set during the through the learning network. Resources, likewise, I think when we want to look at what should be the standard for IPC WASH in facilities, we essentially just replicate what is already available from the learning sites. So that has helped us to advocate right materials, right support, even to partners and stakeholders. Our aspiration is to make sure that the learning sites reduce mortality by 50%. So what it takes, whatever it takes to do that, is being replicated. So I would say that the network to Malawi has been a big help to respond to COVID-19. Thank you, Deb.
And thank you for your leadership within that network. So now I have a question for all panelists. The pandemic has rapidly changed the service delivery environment. Absolutely. What have you found out about how to learn quickly and adaptively manage? For example, did you identify specific data needs or use any helpful platforms or decision-making protocols when the pandemic hit? Yeah, I don't know, would somebody like to volunteer, or we can start with Dr. Oda Zugo? Dr. Likaka, you're still open. You want to speak?
All right. No, thanks very much. I think that is a challenging issue. I must indicate that in our setting, 85% of the population is in rural areas. And being rural, we want to know, even at national level, when we've got restriction to travel, restriction to gather, we want to know what is happening at every corner of the country. So I think the response, to me, what we've learned throughout the whole COVID-19 pandemic is on setting up mechanisms and systems for responsiveness and data. I think they need to move from paper to electronic or digital. I think is very, very vital. We've had scenarios where we wanted to know what is happening in one rural area in real time, just even to know what support that district need, or even the quantities of IPC materials or PPEs required, or even to know the number of staff available in one area when we can't move out. So one area that I've learned, I think that we need to start addressing and investing is real-time data, so that decisions can be made quickly and effectively. Using a paper may not help to respond. For family planning commodities, we had districts that opted to use, local ties, because they couldn't access us. We couldn't know that they need code clamps, and really it was pathetic. But in an event that we have real-time data systems, it's easier to respond. So I think that's the biggest lesson that I would really encourage. Investment in the data systems and the responsive data system, real-time decision systems that are providing data to make decisions in real time. I think that is very, very paramount. Thank you.
Yeah, it sounds like your new division with digital health is going to lead the way on that. So I don't know, Dr. Oda Zugo, let me read the question again because it's been a while. So the pandemic is rapidly changing the service delivery environment. What have you found out about how to learn quickly and adaptively manage? For example, did you identify specific data needs or any useful and helpful platforms or decision-making protocols? Over to you.
Yes, thank you, Deborah. So first of all, I would like to agree with Dr. Likaka in that it's about time, developing countries like mine, like Nigeria, we move to electronic data management systems, but just to also say that there are 170 million mobile phone subscriptions in Nigeria. That might not account for a lot of the rural areas that we work in currently, but I would say that the mobile phone technology was quite helpful and quite useful, to frontline healthcare workers and their managers to be able to collate real-time data. And one major data point that needed to be included in what was tracked was really how many health facilities are open during the pandemic, and open meant, functionality had to change somewhat in the sense that, okay, our healthcare workers equipped with protective gear, is there space within the health facility to be able to provide private counseling, for the increasing number of people that were now coming to the health centers, for GBV services as an example, and also we had to customize data indicators to include data that were coming from the communities to better inform us of what the needs of the communities were. But yes, it's a challenge, having to deal with a paper-based system. But just to say that our partners and governments, were able to use what was within reach, which was mobile technology. And we're learning. I just learned about using drones. We know about drones, but maybe it's something we could also try in our rural areas for monitoring and supervision. Over.
Lots to learn, and I think there's a lot to share, which makes this type of webinar really, really useful. And so lastly, Dr. Anwari, would you like to speak to these the rapidly changing environment and what you've learned? Dr. Anwari?
Yes, yeah, that's great questions. Actually, during COVID-19, when we reviewed the data, we found that, yes, that's a significant reduction in the RMSH indicators. So we established a platform called the RMSH Advocacy and Coordination Committee, which is representing the Ministry of Public Health, relevant departments, and also the NGO representative, as well as the donor community and technical partners, UN agencies. So these were part of that, and we demonstrated that data for them. So this was very interesting for them, and we hope that we should keep such kind of platforms to regularly present the data to the leadership of ministry and making action points, especially in those critical areas where support needed, either from the government side or from the international development partners. So this is one approach. And the other is also, we practiced, it's like a pilot, was the use of mobile technology, and I hope that it should also be continued. That with this, we made a kind of questionnaire, and for some key indicators, it was not only for the technical aspects, clinical issues, but also some managerial issues. We put some questions, about 15 to 20 key questions, and called to our health workers at the health facility, especially in remote areas and hard to reach area or unsecure places. And with this, we asked them, it takes about 15 minutes to or 20 minutes to call them and find the answer from this question. So with this, we can take, we got real-time information from the facilities that what kind of challenges they face, or what is their key achievements, what kind of support is they needed from the government side. So this is also a very good, I think, exercise, and also initiative that the RMSH Directorate, Ministry of Public Health, took this. And I hope that this should be continue regularly, and also have a kind of follow-up that the health facility staff should be ensured that, okay, when they are calling us, they are going to follow up and solving our problems. So this is also, I think, it's a good practice that if other colleagues also should do this, to get a real-time feedback and information from the field sites. Over to you.
I think that's a great way to end this program. We really need to understand what's going on in the field, and there are various and assorted ways to do it. And I think, you know, in the end, if nothing else, take the phone, call them, and get the information on what's really happening. Because I think that's probably been one of the real challenges in the COVID pandemic, is just not knowing, are the health workers showing up? Is as I think Dr. Oda Zugo said, are they even open? Because maybe the health workers aren't there. And with that, I want to thank all three of these marvelous presenters. I'm sure all of the people who are participating and listening in have learned a lot. They know who they can contact if they have more questions. And with that, I now want to introduce Dr. Koki Argawal. She's the project director for USAID's Momentum Country and Global Leadership. She really doesn't need any introductions. She's an internationally recognized expert in safe motherhood, reproductive health, and family planning, policies and programs. And she also is well known for promoting policy dialogue and advocacy for policy reform. She has more than 25 years of service delivery experience, and for more than 2 decades has led, managed, and implemented large-scale USAID-funded global health projects. She's a real delight, and we're always pleased to be working with her. And she's also the Vice President of the DC operations for JPIGO. And with that, I turn it over to you, Koki.
Thank you so much, Debbie, for that very kind introduction. And I really wanted to echo the thanks to all the speakers today for such a rich discussion, and a special thanks to Debbie for such excellent moderation of this session today. I just wanted to close by saying that it has been half a year since COVID-19 was declared a global pandemic. And in that time, countries have seen disruptions to essential services, developed strategies to restore those services, and have made many course corrections and pivots along the way to address challenges like we heard today. Through this country exchange knowledge series that we've had, USAID's momentum, country and global leadership has been able to highlight experiences and emerging learning from a wide range of countries, including Bangladesh, Ethiopia, Ghana, India, Tanzania, Sierra Leone, and now today from Malawi, Afghanistan, and Nigeria. One common thread that all presentations touched on is strong national response must be based on a foundation of timely and accurate data. We heard from Dr. Anwari in Afghanistan how the Rmsh scorecards are being used to improve accountability and focus attention on areas needing the most urgent attention during this time. By comparing this year's data to last year's, to 2019, the Ministry of Public Health has been able to quantify the magnitude of service disruption and is working to develop strategies to address drops in essential maternal, newborn, and child health services. Our other presenters today highlighted what some of those strategies could look like Nigeria's multifaceted response to address increase in gender-based violence since the time of the pandemic has targeted all levels of the health system. One promising approach has been to designate GBV as an essential and integrate this into reproductive, maternal, newborn, and child health and nutrition services. Dr. Likaka today showed how Ministry of Health in Malawi reacted to significant reductions in quality of care indicators by strengthening district level leadership, modifying health workforce, including community health workers, and institutionalizing adaptive learning. There are so many other strategies and approaches that are working. Countries are starting to report that service delivery levels are increasing after the initial drop at the start of the pandemic. As stay-at-home orders are lifted and communities are reopening, it is critical that countries continue to address the disproportionate effect of the pandemic on women and vulnerable groups, apply innovations to maintain quality of care, and use data to guide their approaches. Thank you again for joining us, and many thanks to the speakers and our wonderful moderator for today. While this Country Knowledge Exchange webinar series comes to an end today, we hope to continue this conversation so we can build back better, applying scaling up innovations that have worked under pandemic response to make our health system more resilient and more efficient. We look forward to more opportunities to share learning as countries continue to find effective ways to maintain quality maternal, newborn, and child health services and family planning care. Thank you so much.
I think that's over and out. Thank